Good morning and welcome to the Healthier Washington quarterly webinar series. Today we are focusing on building equity into health system transformation. My name is Laura Kate Deichkin and I'm the Deputy Chief Policy Officer at the Healthcare Authority and the Healthier Washington Coordinator. So as the title suggests, today we're going to discuss the critical role equity plays in Washington's health systems transformation. Before we start, we'll touch on a few housekeeping details and make some introductions. So before we get started, let's just make sure we're all connected. If you can hear and see all of this, congratulations, you're connected to the webinar. You do have two audio options, so you can connect by dialing in using the audio pin, or you can connect through your computer. We are going to be collecting questions throughout the webinar, although we'll wait until the end to do some Q&A. So please make sure that as you have questions throughout the webinar, submit them to the questions panel. Our agenda today is focused on just some level setting around health equity. We'll get into definitions and context. We'll talk about why equity is important. We will give a little lay of the land for what health disparities look like in Washington State, and we'll talk about Healthier Washington and health equity. And we're very privileged today to have an equity spotlight with one of our accountable communities of health in Washington State, Better Health Together. So today's presenters, we have a great lineup from the state as well as from the Better Health Together accountable community of health. We'll kick it off today with Sue Birch, who's the director of the Healthcare Authority, to make sure that everyone remembers what Healthier Washington is and what we're doing here on this journey toward health systems transformation, and really put Healthier Washington in the context of equity and reinforce that a healthier Washington is an equitable Washington. Catherine Weiss, who is a senior health policy analyst, will talk about sort of the landscape of health equity and health disparities in Washington State, and make sure to really define what we're talking about when we talk about health equity. And then we'll hear from Hadley Morrow, who is the Associate Director of Community Engagement from Better Health Together, and she'll be talking about community approaches to equity. And then we're going to round out today with Q&A from this great panel. So I'm going to now introduce Sue Birch, who is the Director of the Healthcare Authority and the Executive Leader for Healthier Washington. Sue.
Thank you so much, Laura. So hi, everybody. Happy lunch break, and thank you for being with us. I want to just make a few comments and kind of refresh about Healthier Washington. It's really amazing how Healthier Washington is transforming our health system, and we really capture this in these three main areas of achieving better population health, rewarding higher quality care, and then curbing healthcare costs. And it represents patients, providers, payers, purchasers, community advocates, and others. Everybody working together, supporting best practices, and using data to improve the lives of all Washingtonians. Now, Healthier Washington really embodies the commitment of our state and its many public and private partners, and we really want to stay focused on this improvement of health of our people and our communities. And we're accomplishing this through those strategies of value, innovative healthcare payments, and purchasing strategies that get those better health outcomes. We're also very committed about sustainability planning as we round out the final year of the SIM grant, because everybody remembers it ends January 31 of 2019. But it's really critical that we carry this work forward through the 5-year Medicaid transformation work. This is all supported through landmark legislation that supports these principles of paying for value, integrating, creating greater transparency, creating greater clinical community linkages and supports. So if you move on to the next slide, building equity into our health system, we're really discussing this topic in detail, and we want everybody to really come together on this issue, that we really can't advance the aims and strategies of Healthier Washington within an inequitable health system. And while we are making great progress, the health disparities in our state remain really pervasive and widespread. So we have to be laser focused about bringing up this issue of equity. The reasons for inequities are numerous and intertwined. I think everybody knows that I have a strong bent towards bringing in the social determinants. And we want to promote equity because it requires the attention to these root causes of health issues and focus on the communities that are most affected. Washington's community of colors face a disproportionate burden of disease, and disparities between men and women still exist within the healthcare system and within our systems at large. We've got to apply health equity lens at all the levels of our work. Now, some examples of building equity into our health systems include things like offering culturally specific multilingual services for non-majority patient populations. And another example is recognizing the influences of adverse childhood experiences and generational trauma on one's health and behavior. And another example is employing a diverse and inclusive workforce that mirrors the populations we serve. Many of us were exposed to the article in the New York Times recently about African American maternal mortality. So in tandem with all of you, our community and state partners, we really want to build a health system that is responsive to all people, all communities of colors, no matter their identity or their background. So I'm going to turn it over to Catherine. Catherine has been so wonderful and willing to sit also at our poverty roundtable. And Catherine, I'm going to let you take us into building equity.
Great. Thank you so much. So first off, I want to start off with some definitions. I think depending on who you're talking to and what you're talking about, you might hear different definitions around equity and health equity specifically. So on this slide, you will see a couple definitions. So the first definition is for health equity, which is health equity exists when all people have the opportunity to attain their full health potential and no one is disadvantaged. The next term I want to define is health disparities, which here the definition is differences in incidence, prevalence, mortality, or burden of disease and other adverse health conditions that exist between specific population groups. And finally, the third term that I want to define is the social determinants of health. And here you will see that the definition we are using is those elements of social structure most closely shown to affect health and illness, including at a minimum, early learning, education, socioeconomic standing, safe housing, gender, incidence of violence, convenient and affordable access to safe opportunities for physical health, healthy diet, and appropriate healthcare services. So while all of these definitions are often used in this conversation around health equity, I thought it was important that we talk about the differences because these terms are not the same, but they do influence each other. And so on your screen, you will see a diagram that shows the relationship between these different terms. So if you're looking at this diagram from the left to the right, you will see all of the different factors that can influence a person's health outcomes and health status. So you will see that race, ethnicity, gender, class, all of those things influence whether or not a person faces health disparities. And all of those influence the system that we work with. So moving on to the next slide, why is this important? Why are we talking about this today? And I imagine that most people on the phone are probably calling in and watching this presentation because health equity is important to you, and this is probably work that you've already been doing through your own organization and community. But just a few things to highlight here. First of all, health equity is about equal opportunity. And that means that no matter where you come from, what you do, what your background is, what your race, your gender is, that you have the equal opportunity to access healthcare, and the opportunities that build a happy, healthy life. Currently, 30% of Washingtonians' population identify as people of color. And this number is only growing, and so it means that we are not dealing, when we talk about disparities, and particularly the disparities facing people of color, we are not talking about a small population. This is a significant population that is growing. So moving past maybe a moral impotence for this, we need to talk about how this population facing disparities is actually affecting our bottom line. And so one report showed that eliminating health disparities for minorities would reduce medical care expenditures by $230 billion. And that between 2003 and 2006, which is now 12 years behind us, we can only imagine how it's growing, but almost 1/3 of direct medical costs were associated with health disparities. So on the next slide, there are a couple of graphs here that represent just a couple of the disparities that we see in Washington state. And this is, again, a few years old, so the data will look different, but the disparities are relatively the same. And you will see that with looking at asthma and the prevalence of asthma, you will see that males had a lower asthma prevalence compared to females, and that non-Hispanic and Asians had the lowest asthma prevalence, followed by Hispanics. Additionally, you'll see on the farther right graph that Blacks, Hispanics, Native Hawaiian, Pacific Islanders, and Asian, American Indian, Alaska Natives had higher prevalence of diabetes than their white counterparts. I do want to take a moment to note, though, that while this data is disaggregated by race, it doesn't necessarily show the complete picture. If we were to disaggregate the Asian category, we would see even more disparities just within that community. If we were to look at the Vietnamese population versus the Korean population versus another population. And so it's really important to look at this, but to also understand that within different communities, there are different disparities, and they're influenced through a number of different factors, as we saw on the previous chart. So to learn more about the disparities facing Washingtonians, there are a number of resources out there, including, I'm sure, resources that come from your own organizations. But I did want to highlight some state resources that have helped shape our work, which include the Health Impact Review from the State Board of Health, as well as the Washington State Department of Health Social Determinants of Health Population Explorer, all of which can help you get a better picture of what kinds of disparities, health disparities, and also other disparities exist in our state. So moving on to Healthier Washington and the work that we're doing here. So on the screen, you will see another definition of health equity, and this is a definition that was agreed upon by our Communities and Equity Committee, which I will talk about more in a moment, but it really highlights that there are a number of different factors that impact a person's ability to access health and health care. We called out a number of those, but this is by no means a comprehensive list, but rather the start of the conversation. So health equity has been a part of Healthier Washington's mission from the start. When the Medicaid transformation waiver started several years back, we embedded health equity into our special terms and conditions. And those special terms and conditions are the rules that dictate how we implement the Medicaid transformation waiver. And so it's really important that health equity is part of that. And you will see here that we call out improving health equity and reducing health disparities as part of that work. Additionally, our accountable communities of health, and you'll hear from Hadley from Better Health Together in a moment, are also responsible for moving certain metrics as they relate to the social determinants of health. Those metrics are associated with different projects based off of what the ACHs decide to choose and focus on. And also ACHs as a whole are really committed and dedicated to building this equitable system of healthcare, and have all engaged in their own work to help further opportunity for Washingtonians. As for specific Healthier Washington work, we are currently working with our Health Innovation Leadership Network, which has a great interest in health equity. It's a group of leaders in our community from health systems and community-based organizations and advocacy organizations who are focused on building the system with us. And with that group, we have a subcommittee called the Communities and Equity Committee. And this committee has decided to target a few areas for focus, not because these areas are the most in need necessarily, but because these are areas where we think we can possibly move the dial in conjunction with the other work that we are doing, because it's important for us to be able to create tangible change and measurable change so that we can build upon it as we move forward with this in future years. So what's coming up next as it pertains to health equity in Healthier Washington? So as I mentioned, our Health Innovation Leadership Network has committed to focusing on equity, particularly as it pertains to whole person care. Additionally, we are hosting an October Learning Collaborative in the fall that will have a huge emphasis on equity, and we're looking to bring in different speakers, keynote speakers, and panels that can talk to creating a system that is built upon equity. And another thing that we're doing that I just wanted to highlight here is working with some of our state partners to help create tools and resources that can be used to support our partners in building their own equitable organizations. And so we are currently working with the Governor's Interagency Council on Health Disparities to help build tools that can be utilized by other agencies and by our ACHs to help diagnose and create solutions for inequitable services that currently exist. So with that, I am going to pass it on to my colleague, Hadley Morrow, to discuss what her ACH Better Health Together is working on as it pertains to health equity.
Thank you so much, Catherine. I am so happy to be here and grateful for the opportunity to share with all of you a little bit about Better Health Together's health equity journey. It's been a lot of learning for us and a lot of exploration, so I'm excited to get to sort of walk through that with you all today and eager to hear your questions as well. Next slide. So Better Health Together has had the unique opportunity to impact change in our Medicaid delivery system as one arm of the Healthier Washington initiative. We are the backbone organization for an accountable community of health, which serves 6 counties in Eastern Washington. It's the Northeast Tri-Counties, up next to Canada, Adams and Lincoln and Spokane counties. We have quite a diverse region, with Spokane being sort of a metropolitan center, an urban center with a lot of healthcare resources, and then our rural counties being much more geographically spread out, less populated, and having some more, resource challenges of their own. So there's been a lot of learnings to sort of navigate as we've gotten to know our region and what the priorities are to our folks. Really, the mission of Better Health Together is to work with community partners, healthcare partners, local government, anybody who's in a position to impact health, and coordinate on some innovative projects that are going to improve quality of care for folks on Medicaid while reducing the cost burden and hopefully alleviating the burden on providers too, so they can really offer high quality whole person care. We see this as directly connecting to sort of this vision of health equity, because we don't imagine how we can get to a vision of whole person care until we achieve a state of health equity where folks have an equal opportunity to reach their highest health potential. Next slide. Just giving you a little information about the Better Health Together region. We look a little different than the state makeup. BHT is actually 70% white, with quite a bit of difference in the racial disparities between each of our counties. We have three tribal reservations in our region, as well as a high urban Indian population that mostly lives in Spokane. We have primarily an aging population with a very declining workforce. So we have a lot of folks who are aging into the Medicare age, and we are quickly losing folks who are of working age, which is creating an interesting challenge for some of the workforce issues related to healthcare. Additionally, there is a lot of poverty in the Eastern Washington area. About a third of each of our counties, the folks there are on Medicaid. We have a lot of regional housing and transportation shortfalls. This is true really statewide, but especially for the folks who live in our rural counties, transportation can be a big issue. We have some very remote areas where if it starts snowing, a pass can close and you might not have access to a grocery store or a healthcare provider until it melts. And we also are, living out a lot of the downstream effects of family trauma and, families that struggle with adverse childhood experiences, as seen in, high rates of substance use, high rates of mental health issues and depression. We also have a lot of the focus that BHT is doing on our projects right now have been working with folks who are exiting out of jail, where we find that in our Spokane County Jail, about 87% of folks have a diagnosed mental health or substance use issue, which is showing us that there is a lot of trauma happening upstream, that if we could start to move our efforts to work on preventing trauma, preventing some of these disparities, we would save ourselves a lot of costs, a lot of trauma later down in the system. Next slide. I just have to show this map because I think it's really important to us when we talk about disparities, because racial disparities haven't been, it's not as loud of an issue in the Better Health Together region. What we have seen mostly coming up when we ask our communities what the priority is, it's about resources and it's about poverty. So this map shows there is pretty much no area in the BHT region where folks have affordable access to housing and transportation. If you were to be able to see the sort of numbers associated with the colors on this graph, almost every area in the BHT region, except for those light blue areas near Spokane, folks are spending close to 50% or above of their income on housing and transportation. So we have a lot of resource struggles in our region. Next slide. So with that, I really just want to talk about how Better Health Together has been exploring health equity and what channels we're using in our work to really embed it in the work that we're doing. There are sort of three elements that we have been using in our process. The first is equity through community voice. So that's where we're out in the community getting to know what's the priorities of the people who are with lived experience, actually navigating the healthcare system, living life on Medicaid, and trying to, trying to reach their full potential. We are exploring equity as a best practice, looking for opportunities to sort of incentivize or encourage best practice uses of activities that are accelerating health equity. And finally, we're trying to build in incentives for health equity activities in the way that we finance the work we're doing with partners. So I'm going to do a deep dive onto each of the three of these. Next slide. So the first is talking about equity through community voices. We have two main channels where we are really highlighting the voice of our community and the needs that folks are feeling day to day. The first is in our Community Voices Council. This is a council that we have just launched. We actually have our second meeting next week, and it's taken a bit of groundwork to get it up and running. The goal is to have the council comprised of 51% Medicaid beneficiaries, with the other half being made up of community health workers, community advocates, folks with lived experience navigating and helping others navigate the healthcare system. So in this way, we want to create a balance of folks who are current beneficiaries, who are currently accessing the system, exploring how to get their needs met. And also, really these are people who are very passionate about healthcare. They're folks who have some sort of desire to give back to their community and be active. And then the other half is really those who have maybe more of a intricate knowledge of the system, because as they live their lives helping folks navigate the system, as perhaps as a community health worker, they're starting to see some of the challenges, seeing some of the systemic barriers that might be coming up for people, and even more of the logistical barriers that happen for service providers as they're trying to work with clients. The main goals of this group are, first of all, to serve as an advisory board for Better Health Together. So as we are looking at making decisions, all the decisions that we make run through this council first, so they can give sort of an advisory on, hey, this is how we would expect Medicaid beneficiaries to respond to this. This is sort of a safeguard for us so that we don't make decisions without a voice of the community. Additionally, as we move into sort of building out actual transformation plans for how healthcare partners in the region are going to start making changes within their own clinics, their own healthcare settings that are going to affect how Medicaid beneficiaries receive care, we're going to have our Community Voices Council review those plans so they have an opportunity to talk to those providers and say, hey, you know, I'm not sure this would work. I don't know how well this would be received. Let's see if we can tweak it a little bit. The other goal that we have for this group is really honing in on a set of activities that would accelerate health equity. So we want to start working with this group to explore what activities would be cross-cutting across, you know, many of the different healthcare projects and initiatives that we're working on in our region, but really equip providers and healthcare professionals to interact, to really work towards that health equity system. I'll go in a little later to some more examples, but really we're thinking about things that happen sort of within your office. How are you thinking about health equity? How are you using data to make sure that you're monitoring whether or not the interventions you are doing might have an adverse effect on a population? Sort of more of the muscles of a health equity lens to start to drive folks to those activities that are needed to move towards a culture shift of equity. Additionally, this group is going to take on a role a little later once the transformation plans are starting to be implemented, of helping us figure out how we should communicate all of these changes out to the wider public. So how can we be communicating the work that's happening from Healthier Washington and BHG and our partners to the general public in a way that's very digestible and approachable? We have one other arm of sort of a community voice through our Tribal Partners Leadership Council. We recognized early on that because of the unique government-to-government relationship with tribes, we needed a mechanism in our governance system to be able to go to tribes and ask, you know, and to see that same level of advisory work where they could be advising us on, hey, this might have an adverse effect on our tribal partners, or hey, you know, we have some different regulations based on our funding, based on how we work on IHS, and this plan might compete with that. So that's also a monthly meeting that, again, before any decisions go to our board, they are routed through the Tribal Partner Leadership Council so that when the board gets the decision, they also have the input of our Tribal Partners and Community Voices Council. So those groups have really been foundational in helping our health equity learning and just making sure that we are on the right track. And not caught with any blind spots. This group really helps us to keep our eyes open and challenges us to be looking for, you know, other opportunities to advance health equity, but really be a safeguard against possible disparities. Next slide. So this next is really equity as a best practice. And I want to give a quick little story here about a conversation that we had recently at a leadership council meeting. Our leadership council is really our largest stakeholder group. There are, I think, around 100 different organizations from across our region that sit on that council and help to give us feedback on the direction that we want to take our transformation efforts. At our meeting in April, we focused the whole entire 2-hour session around health equity and gave some examples of how BHT was looking at a health equity lens, how some other partners in our region used health equity in their own work, but then really opened it up to a conversation about, you know, if BHT could sponsor one activity to accelerate health equity, what would you want it to be? Just trying to zero in on a few priorities. A really interesting conversation came up as we talked about the phrase health equity lens. Some folks had a really negative response to the word equity lens, and the conversation that came out was, I don't know, it feels like if we say equity lens, there's this pair of glasses that we have to put on in order to think about health equity. And aren't we trying to move to a place where health equity is foundational, it's in all of our thinking, it's embedded into every activity that we do. It's not something that we actively think about because it's just fundamentally part of the work we're doing. This turned into a really interesting and important conversation, I think, because what we landed on was, yes, that is absolutely the goal. The goal of health equity is getting to a place where we have systems that are no longer inherently creating disparities that are affecting a human being's potential. However, I don't think that we are there yet. And because the systems that we're working with have been created with to build and reinforce disparities, we have an obligation and this opportunity to transform the system to very actively apply a health equity lens. I think it does have to be an action that we're constantly reminding ourselves to ask, are we applying an equity lens? Have we thought through how this might affect diverse populations? And are there unintended consequences of the work that we're doing? So I just want to highlight that as sort of a, an interesting note about how BHT is approaching equity and how we really think about the equity lens in our work. We hope that through the activities that we're doing, we are encouraging providers and other members of the healthcare system to start to embed health equity on a fundamental level. But at the very least, we hope that what we're doing is starting to getting people to think about how they could do more to accelerate health equity and be critical of the work that they're doing. Some examples of health equity as a best practice. We looked at some work that came out of Oregon's Medicaid transformation efforts. They did a lot of heavy early work on sort of exploring health equity, and through some focus groups and community work came out with some recommendations for sort of the 4 most popular, most impactful health equity activities, which they landed on applying culturally and linguistically appropriate care. So Sue hit on that earlier, making sure you offer care in in the language that is most accessible to folks and also meets the sort of cultural specificity. People are more likely to succeed if they can find a care pattern that matches their cultural identity. Hiring a diverse workforce, so actually making sure that people who are serving patients look like the patients they are served. This helps build trust. Use of community health workers as an anchor strategy, because those CHWs often have lived experience of what it's like to be on Medicaid or to be struggling with a health issue, trying to navigate resources. And they provide this level of individualized care where they can help folks walk through whatever barriers might be coming up in front of them in a way that's much more hands-on than a large health system could do on its own. And then the final example was a better collection and use of data. So we talked a lot about, disaggregating data. How can you make sure that in the work that you're doing, you're not unintentionally harming or creating disparities across demographics? So perhaps, you run an intervention and you see that hundreds of people got better outcomes, but then if you look at the data, you might see that only, that 75% of those patients were white and 25% were black. That could show that there are signs that there's a disparity there, that your program was not equally reaching people who needed help. So those were some of the activities that we put in front of our leadership council and sort of said, let's generate and brainstorm what would be of high impact to BHT. In addition to those, there was high interest from our community in hosting trainings around health equity activities. A lot of them had to do with stigma reduction, poverty simulations, and sort of getting folks to think differently about disparities. Another example was people wanted to see an opportunity to really align our leadership council work around policy advocacy. We know that policy creates a lot of barriers to folks, and how can we really rally our community to make sure that when we see a policy that might be harming a certain population, how can we get together and create an argument to change that? And then the final example was folks wanted to see Better Health Together really require the partners that we will be paying to start to do these transformation activities to speak to health equity in their transformation plans and really tell us what they were going to do concretely to advance health equity in order to earn some dollars that might incentivize those activities. Next slide. So that gets me to equity and waiver financing. We have a couple different ways where we are really incentivizing providers to embrace health equity work through transformation. The first is in our equity accelerator. So we recently have started asking our providers they all have taken an assessment that started to tell us, okay, what's the current state of your healthcare workforce? What models are you running? What initiatives do you have going? And where would you like to see this work grow? In that, for partners who committed to jumping on the transformation train with BHT, those who are serving greater than a 9% ratio of diverse patients within their patients pool. So if you are serving more than 10% patients of color in your clinic or in your hospital, whatever it is, those folks get an equity accelerator payment. So they get an extra amount of dollars for committing to this work. This is in recognizing that if you are taking on a high percentage of patients of color, you're taking on folks who have higher risk, are more likely to be associated with negative health outcomes, and who are seeing higher barriers to receiving care. So this equity accelerator dollars is supposed to sort of both honor the fact that we recognize those folks are taking on higher risk clients and provide some flexible dollars for innovative opportunities to continue that work. The BHT region, as I said, is about 9% racially diverse. So we set this accelerator payment at 10%, looking for folks who are sort of going above and beyond what is average for BHT. Additionally, we had a similar rural accelerator payment. This was for our rural counties that were experiencing high rates of poverty. So we recognized and heard loud and clear from a lot of our rural partners, gosh, we really struggle with transportation, we struggle with affordable housing, because we don't have the same level of internet infrastructure. There are challenges within our healthcare system. So that rural accelerator payment is meant to help our rural partners have some flexible dollars to overcome the challenges they have just from being often in isolated, resource-starved areas. In the future, we have a couple ideas for how we're going to continue to incentivize equity in this way. That Community Voices Council that I mentioned is going to be looking at the recommendations that came out of the Leadership Council and out of Oregon's work and starting to explore what we could actually do or incentivize around those activities. So they're going to be working towards building a recommendation of what health equity activities BHT might become, say, a sponsor of in our work. Once we build that recommendation, it goes to our waiver finance team, which is responsible for allocating dollars to ACH transformation work. And they're going to say, okay, this seems really worthwhile, and we would like to add, this as an example, they might advocate to offer some incentive payments for folks who agree to take on health equity activities. Maybe that is around, hiring more diverse workforce, getting trainings in culturally competent or trauma-informed care, whatever activities will come out of the Community Voices Council. We'll look and see if we can offer dollars to incentivize that work. And again, all of that would happen, with board approval. So we have a governance process that allows this to move through a number of chambers to sort of talk about whether or not this would be high impact for BHT. And next slide. So that's just a quick rundown of sort of how we're approaching health equity, how we're building it into the work that we are doing. You can see my contact info is up on the screen. I am more than happy to talk about this work all day long, and especially talk to folks who are interested in seeing how they can maybe start to do some of their own health equity work. So I'm happy to take questions or receive any contact if anyone would like to hear more about what we're doing at BHT. And otherwise, I think we're ready to open it up to questions.
Thank you so much, Hadley. We do have many questions for you, but before, we did receive some questions about some population-specific data and things along those lines, and so I would point back to that last resource slide to really dig in. If you are interested in specific, if those on this webinar are interested in some specific data points about populations, about different areas of the state, or just general health equity resources. And I believe that these either are linked here today, or we will definitely be posting these slides, and we can, and you can link to them from there. So now we are moving into Q&A, and so now is the time to type your questions into the question panel so that our speakers today can address those questions. We did receive many questions during the webinar. Some of them have been addressed already through some of the presentation. Again, I would direct folks to some of the population-specific, geographic-specific resources. And then we also have some specific questions here. So I might actually kind of take us to a question that gets us at a high level and harkens back to some of Sue's earlier examples about what equity might look like if we were to advance and even accomplish the vision and the definition here. So Sue provided some examples about culturally responsive services and workforce. And Hadley, you talked about sort of that equity lens concept, which was a really interesting story. I'm interested from both of you, if we advance equity in Washington State, what does that look like? And how do we know we're on the right track? And I think, Catherine, I'll start with you, and then Hadley would love to hear your perspective as well.
Yeah, thank you, Laura. You know, I think it can look a lot of different ways, but it definitely, this question makes me think of a story I heard a little while ago from a Seattle-based midwifery clinic that helps serve communities of women of color and provide culturally competent services to their clients. And they told me a story about an Islamic woman who went to them for care because she was hoping to look for care that aligned with her religious and cultural beliefs, and then they ended up having to take her to the hospital. And in that process, that woman ended up going into labor, and a white male doctor, in an attempt to provide good care, inserted his hand inside of her without saying anything, and ended up really doing some psychological damage to that woman. And I think that doctor would probably say that it was an emergency and that work had to be done, but I think in this new end state vision, that doctor would have had the training to understand how that woman might have had experiences related to that could really do some psychological damage to her, and that that woman and that doctor would have had a completely different interaction if our work is successful. And so I think of a woman getting services that really reflect her own values and her own beliefs, and really takes care of each person based off of their own needs.
Thanks, Catherine. Hadley, I'll turn that question to you. What does it look like in your community if we were to advance this, and how do we know we're on the right track?
Yeah, you know, I think first of all, my mind goes to, we'll see it in the data. So that, you know, the slide that Catherine showed that showed the disparities among different populations for asthma and diabetes, you know, we would start to see that chronic disease isn't impacting people differently based on their race. And you can apply a lot of different, you know, you can fill in the blank there for chronic disease and race. You know, we could also see mental health and substance abuse wouldn't impact people based on their poverty level. So we'd get to a place where actually you know, the data is showing us that people are not experiencing those adverse effects, or that populations are not experiencing negative health outcomes with these disparities. But at the same time, I think that there's also sort of a culture shift that's happening that speaks more to what Catherine was just sharing in the story, which is we get to the place where providers, you know, and everyday community members are really equipped to greater understand, you know, really what is privilege and why do disparities matter? Why does this work matter? So folks that are equipped to be more self-critical and ask the questions, you know, are there barriers for this person that I may not see because I haven't lived that experience, but they're still credible, and that we need to take a, you know, community-wide approach to overcoming. So I think there's sort of, you know, there's both the outcomes. We would see better outcomes for all people, and I think we would see a culture shift where folks are, you know, able to really to honor the different backgrounds and the different lived experience that everyone comes from, but still have an opportunity to succeed in the same way.
Thanks. So we've received a lot of, well, there's a lot of equity activities going on in Washington State, and some of the conversations that have been happening at community tables, statewide tables, some of these public-private leadership tables, is really an understanding that in order to really move on this, there needs to be a transfer of power, authority, and resources to community members and to the community level. So Hadley, this question is for you. You talked about the structure within the Accountable Community of Health organization or collaborative as really through the Community Voices Council and otherwise. We've received some interest in some elaboration on how this translates at the community partner level. So specifically, where are you seeing some movement for health plans, providers, and community-based organizations to really make this transfer of power and authority occur?
Sure, that is a great question. We're just slightly a little too early in the BHT process for me to give you some really concrete examples, because we've just sent out our template for our community partners sort of transformation plans. In the plans, we have asked them to speak to their use of a health equity lens and also their community engagement activities. And that's one area where we see a big opportunity to help try to push some of those, push the power structure back into community and really elevate the community voice. So one thing that we're trying to do there is ask providers and build the expectation of providers that as they make this transformative work, we need to see a way that they are asking their clients, the community that they are serving, whether or not this is working, that they have some sort of community engagement mechanism where they are really trying to seek feedback, to hear ideas from their client base, from their consumers, so that that voice can start to be elevated within the power structures of each of our partners, sort of hoping that this can have a cascading effect. I think we saw just an enormous amount of opportunity in the way that the ACHs were structured through the waiver opportunity in Washington State, basically saying we trust that local communities are going to know what's best for them. So we're going to give this opportunity to 9 accountable communities of health who are going to spend a couple of years really out in their communities getting to know what the priorities and what the issues are. And what's risen to that is a really great set of projects that came out in the transformation toolkit that have really mirrored some of the most pressing priorities of our community. And because of that, it hasn't been, really hard to generate buy-in to do this work, because it's stuff that people already knew was really needed. And I think that if you can make sure that that's sort of how information is flowing, that it starts at the community and that voice is elevated to the top and then honored in a way that the needs are acted on, we can start to see sort of that shift.
Thank you. We had some specific questions, Hadley, about the Community Voices Council. You mentioned that 51% of those council members are Medicaid beneficiaries with lived experiences. Just from a status check kind of perspective for that council, how many people are on it, and what work is being done to support and kind of translate in many ways for these individuals?
Those are awesome questions. So we are, I think we're at about 15 people on our council, and our goal is to get it up to 30. We have taken sort of a slow and steady approach because a lot of the folks who, a lot of the beneficiaries on our council, this is very new to them, and the healthcare transformation is happening in a lot of jargon and a lot of acronyms, and we as BHT staff are trying to be really, really thoughtful about how we onboard people so they don't feel overwhelmed, and so they really feel empowered to be part of the conversation. And because of that, sort of our recruitment and build out of this group has been pretty slow. We really started with looking at folks who were trusted leaders and community advocates. We actually had a nomination process through our leadership council where we said, this is the criteria we're looking for in a community voices member. We want people who are passionate about, helping improve lives in their community, people with lived experience navigating healthcare systems and complex issues. We got a number of nominations, and then we're able to use those people who were nominated as sort of community champions who then went out and recruited Medicaid beneficiaries. So one, I think, important element is we're trying to do this sort of almost a partnership model where there is there's a beneficiary, but for every beneficiary, there's also some sort of community advocate who has done the outreach, who recruited them to come to the group. So there's never a cold handoff. And that has really helped us in keeping folks engaged and interested. Additionally, we are moving towards trying to figure out how we can get these, our beneficiaries and Community Voices Council members really integrated into other elements of Better Health Together's transformation. But again, in a way that's not overwhelming or, for example, I feel nervous inviting a Medicaid beneficiary to one of our Provider Champions Councils, because at those meetings, I don't even understand half of what they're saying. They talk a lot in healthcare terms. It's a lot of jargon. There's a lot of very technical conversations going on. So in order to have beneficiaries there and really feel comfortable sharing their voice, we're envisioning a model where we sort of pair up. Beneficiaries come with a community advocate, so folks would always come in pairs of 2. And then, we're going to need to do some coaching with all of our other councils and start to sort of say, hey, our Community Voices members are going to start showing up. They're going to start to be an integral part of this group, and that might mean we change a little bit about how we talk, about how we function, in order to make sure everyone feels comfortable and on the same page. There's been a lot of learnings in this. I'll just, one very interesting story. At our last meeting, we were at a room in a basement that had been a great room for a lot of community meetings, and somebody said, I just want to point out that I actually have post-traumatic stress disorder, and it's really, really hard for me to sit in this room because there's only one door and no windows, and the only seat available didn't face the door, and I couldn't focus because I didn't feel safe. That was so powerful and really showed us, wow, like we have to think really thoughtfully about how we're building out this group, from the basics to where the room is to how people are brought up to speed. So that's a great question. We've had a lot of learnings on that.
Thanks, Hadley. There was a theme both at the community level and at the statewide level around data disaggregation, and really making sure that we are measuring and actually improving the way that we measure and report on disparities. We had a question around that when it comes to statewide timelines and trajectory. I would just kind of address at this point, and then I'll turn to Catherine, see if she has anything to add, that this is a journey for state agencies as well. There is recognition across state agencies that the way that data and display of that data has been put together is not as culturally responsive as we would like it to be. And so we are using some of our actually own internal data and analytics support at this point to understand how we can improve our own processes and policies, and then start to talk to our partners using that data and also to evolve that data. So more to come, I would say, from a state agency perspective, as I would suspect this, continues to be an evolution at the community level as well. Catherine, would you add to that?
Yeah, I think data disaggregation has definitely risen to the top as an issue that is really important to our partners across the board. And as many of us know, averages hide disparities. And in order for us to attack some of these problems that are being faced by our communities, we need to disaggregate that data, disaggregate it fully, and then we can start measuring what we need to understand better. And I always think that, like, you measure what you value and you value what you measure, and it's important that we value measuring this health equity work.
Thank you. So we are at the end of the hour, and I want to recognize that we did not get to a lot of specific questions, both largely for Hadley and BHT. So we'll be huddling back with Hadley to make sure that we can get these questions and comments to her, and then also see if there's a way that we can specifically address some of these more deep dive questions, or just broader questions that we weren't able to get to. I would also note that this continues to be something that Healthier Washington, as really a movement toward health systems transformation in Washington State, wants to align with partners on. As Catherine said earlier in the webinar, we are not looking to reinvent the wheel. We're looking to build upon aligned support and advance a lot of this really great community level, regional, and statewide effort that's happening in equity in Washington State. So in addition to getting in touch with your ACHs, Hadley made a great offer to get in touch with her if you have specific questions. We would ask that you stay involved and informed and provide us feedback to Healthier Washington as a whole. And the way that you can do that is to join the Healthier Washington Feedback Network by going to the email or the website on the screen here. You can share your health system innovation story through the Voices of Healthier Washington platform, and we would welcome outreach to HCA in order to move that forward. And then please join the conversation on Facebook and Twitter and other social media outlets. Thank you for joining us today for this quarterly webinar, and thank you to our panelists, Sue, Catherine, and Hadley. Have a great day, everyone.